The research suggests that in children, 85% of the time it's going to be the hyperactive variety, the combined presentation. The other 15%, about half of them might actually be hypoactive. And there is, Barclay talks about sluggish cognitive tempo, which is like, he says is really, it's an attention deficit disorder, but it is kind of its own thing there. As far as treatment goes, the treatments are pretty much the same. I mean, you know, you treat ADHD with it. It's just that if you don't have the hyperactivity, well, then God bless you. I mean, that's a wonderful thing you don't have to mess with. But a lot of the treatments are pretty much the same.
The only caveat I would add to that is as you go up on the dose of the stimulant medicine, you capture first attention and focus, and then you go up some more and you get the impulsivity, and then you up some more and you get the hyperactivity. So sometimes with inattentive type of ADHD, I found that the doses don't have to be quite as large.
You talk about the benefits of the medication in brain development, and is there an age? You know, like usually we start like at 6, or what I'm wondering is like they have seen like there an age that is like a little too late to see those benefits in brain development?
You know, I don't know if there's been enough research to answer that particular question. What they looked at was people who had been on stimulant medication for a while, since childhood. So I don't know. We know that if someone's never been treated, they're 45 years old, they get on a stimulant, that the stimulant is treating the core deficits of ADHD. You know, it's still improving attention, it's still improving impulse control, and it's still improving executive functioning. Now, the hyperactivity, we used to say people would outgrow it. We used to call it the hyperactive syndrome or hyperkinesis. And what we found is a lot of the hyperactivity calms down by mid to late teenage years. But even adults, I mean, I'll have an ADHD adult in my office, and they'll be sitting in my office pretty still, except that foot is just going a mile a minute. But they're not up out of their seat, they're not crawling the walls, but that foot is going.
I think that's it exactly. And as far as at what age do you begin to treat? Okay, so numerous medications have been studied down to 4. What I look at in deciding clinically if I'm going to do that or not is the degree of dysfunction. So if I have a kid that's been kicked out of daycare, the parents work, no one will keep the child, it's a danger because the child's running off or climbing up on high things and falling off, then I'll go, okay, we'll try. Little preschool age kids notoriously get very emotional with stimulant medicine. And so I will tell them, heads up, this may not work. And you can go more with the 10X and the clonidine, but there again, you've got to worry about blood pressure in such a very small child. So I don't rush to treat those children. But if the dysfunction is such that not only they, but their family is not able to function well, then I will try.
Obviously, emphasizing pediatrics, what about the other end of the spectrum? You mentioned it's a lifelong disease or process or abnormality. Someone's doing well on their ADHD medicine, Adderall, pick whatever you want, and now they're 55, 60, 65, 70. Is there an upper limit where you would stop the medicine and say, you've reached the limit?
No, no.
Now, I've seen lots of people in their 60s still on medication. They've been on it 40, 50 years.
Yeah. If it's not broken, let's not try and fix it. Unless you're suddenly having big problems with hypertension or whatever. No, there's not an upper limit.
But one of the things, and I'd like your comment on this, one of the things I've seen is that some adults can actually be on low dosages of stimulants. I mean, I know one adult who would take a 10 milligram and cut it in half, and then take the 5 milligram and cut it in half. And so they're taking 2.5 milligrams, and that seemed to be enough to work. Now, They were on a whole lot higher dosage when they were a kid and a teenager, but now that they're 35, 40 years old, just a little bit seems to work. I mean,
Yeah, I see that as well. Not always. It's not a uniform deal. Some still need pretty good dosages. I think a couple of things have happened. One is their liver isn't quite as active as it was when they were a kid, because you have that first pass phenomenon where all the medicine's getting sucked up before it gets into the bloodstream. The other thing is that you're not having to control the big hyperactivity anymore. The other thing is that they're more mature. And for those who have bought into this is what I have and what I have to do about it, then they're not as dependent on high dosages of medicine to make that happen. And your idea about writing it down, a calendar, when people check out at my office, they go to Stephanie, and she gets them an appointment card with when to come back, and their telephone number, because she's going to call and remind them. Okay? So the patients that are not coming back are the ones where the parents have dropped the appointment card in the driveway, and I go and find them. Those who stand there at the desk and say, wait a minute, let me put it in my phone, pull out their calendar out of their pocketbook, write it there, and say, give me the card, I'm putting it on my visor. They're coming back for their appointment on the right day. Probably the right time. But they've bought in. They've said there's some things I need and can do about this.
Do you know anything about the long-term effectiveness and safety of melatonin? If we can have like kids on it for a life, or how that, if I have teens, who don't sleep.
Yeah. So there's variable research out on that. I don't think that there is any reason why you can't keep taking it if it keeps working. Now, I do have kids that it will work for, and then it'll quit working. So we take them off. And so then I say, okay, let's see what we got next, and maybe I'll put them on clonidine. Well, clonidine will quit working too, because you develop tolerance to it, and I'm not just going to keep going up on the dose. So I'll take them off the clonidine, put them back on the melatonin. Say, all right, let's see how long this works this time. When it quits working, I may put them back on the clonidine. You just have to go with what works.
Yeah, the other thing I'd say about that is that with all the electronics, the little red light, little dot, and especially the blue light, will keep people awake.
Yeah, and they don't
Terribly
believe
disturb
it.
sleep. And the blue light, it's the frequency of the light that does the if you actually see the electronics, it's clear. It only becomes blue when the electricity is going through, because it's the frequency. So the blue lights are deadly to sleep. And so you've got to get duct tape or some electrical tape and put it over that. If there's any light at all in the room, it can disturb sleep.
And the child will say, I can only fall asleep with the television going. Well, that's the way you're falling asleep now. But there are other ways to do it, And part of what they're saying there, and you will find this with kids when they're trying to do homework or in the classroom, or adults that are trying to do things, they may have their tune zone because it keeps a part of their brain occupied, so that then they can zero in with the other part of their brain and be successful. And so kids that are up and moving are more likely, if they have ADHD, to be able to learn some things than if you make them sit still. You have to allow for that kind of thing, to use that as well with them. And good sleep hygiene. Kids with ADHD have a high comorbidity with sleep disorders. They do. And the sooner they can begin to get into a regular routine, and one of the things that is killer, my voice doesn't carry very well, so I'll stand up. One of the things that is killer is the summer vacation. We're going to stay up late, and we're going to sleep half the day. Well, that may work fine for this summer, but come August, you're going to be hurting. And so I really encourage them not to go wild with it. Now, a lot of what I say gets ignored. But it works out better for them if they will stick to something semi-normal on a sleep schedule.
So when you first start a patient on medication on a stimulant, do you usually start with short acting, and then if they tolerate that, go to long acting?
If I have a little bitty kid, you know, little tyke, 40 pounds-ish, I'll probably start short acting.
Okay.
Otherwise, long acting. I just go ahead and give them the long acting. Unless I'm worried that that's too much medicine for them. So that's when we go back to the small kid thing.
Okay.